Welcome, emergency departments across British Columbia. It's time to sign your charts because you have reached your end of shift. You're listening to End of Shift, a podcast brought to you by the BC Emergency Medicine Network. I'm your host, Eric Angus, along with my friend and colleague, Joe Hager, bringing you an eclectic mix of clinical pearls and discussions about the philosophy and practice of our craft and yours, emergency medicine. This is episode number 5 of End of Shift, Who Needs a Hand Job? We'll be talking to Dr. James Saunders about common hand presentations, work, and treatment. In the ED, we see lots of injured and infected hands and need to be comfortable with initial diagnosis, treatment, before considering downstream follow-up with a hand surgeon. Joe, you are sitting in fast track when the nurse brings in a young man clutching his right hand. His demeanor suggests he is a businessman of some sort.
Let me at him.
He's a 24-year-old male, and he presents to you following an altercation. Blows are exchanged, and he complains of a painful right wrist and hand. He's sitting down, normal vitals, no other complaints. He's swollen over the 4th and 5th metacarpal heads and shaft and has a small laceration over the 5th metacarpal head as well.
Well, I think what you're asking me is what should I do? And I think what I'd like to do is I'd like to take a bit of a history, so know the time of the injury, his general health, past illnesses, meds, tetanus shot, whether he's hurt that hand before, what he does for a living, and then I'd examine him and send him for an x-ray and then give him a tetanus shot.
All right. Well, prior to sending him to radiology, the nurse gives him some Tylenol, and the x-ray shows a fracture of the 5th metacarpal neck with the head volarly displaced by about 70 degrees. It seems to be some air in the soft tissues as well.
Well, I'm thinking closed fist injury, and I'm concerned about the bony injury, but the laceration, and what could that mean?
Today we're going to talk about emergency management of hand injuries. Our expert is James Saunders. He is the current head of plastic surgery for the Sea to Sky corridor. He's a clinical assistant professor in the Faculty of Medicine at UBC. James, welcome to End of Shift, and tell us a little bit about yourself.
So a bit about me. I actually started my training at McGill, ended up in med school at UBC, stuck around for my residency in plastics and reconstructive surgery, and then ended up going down south. So I was at Washington University of St. Louis for a couple years, where I did a fellowship in hand surgery and peripheral nerve surgery. And then I came back to my dream job, and that was working at Lionsgate Hospital. Our group is 5 surgeons, and we do burns, facial trauma, a little bit of pediatrics, a lot of hand trauma for myself, and even a little bit of cosmetics now and then we've been known to do.
Thanks again for fixing that little, that little thing.
I thought we were going to talk about that.
Well, I mean, the thing you did for Joe.
Oh, that one, yes.
We're not talking about that.
So right now, my practice consists of a lot of hand surgery. We have a lot of athletes on the North Shore, mountain bikers, skiers, and they all filter down towards me.
James, I understand a large part of your emergency hand practice comes from businessmen.
That's true. We call them business fractures. They're minding their own business.
What do you think about the statement that the best insurance against misdiagnosis of hand injuries is an adequate history?
We're in the midst of COVID right now, and a lot of my histories right now are actually via telehealth. And I'm surprised at how much I can accomplish without doing a physical exam. So I think that's just paying homage to that. It really is so much based on the history.
But you also have the ability to see the patient too, right? And you can get them to look. You can look actually at the body part.
Probably about half the time with telehealth. A lot of our patients are older, and getting them to set up a video chat is just not going to happen. So we do phone conversations with them, and it works out quite well. And for basic things, trigger fingers, which you probably don't see in Emerge, small infections, arthritic problems, carpal tunnel, you can actually work it out pretty easily just via telephone conversation.
Well, I'm glad you brought up COVID, because just as an aside, we are recording this actually practicing some distancing. We've maintained a firm 2 to 3 meters apart as we're recording, just in the spirit of flattening our curve. So Joe, why don't you lead us off with what we're going to talk about first, which will be common fractures in the ED.
Right. So I think we're going to talk a bit about some fractures. We're probably going to talk a little bit about some dislocations. We're going to talk a bit about soft tissue injuries, and we'll come back to the start-off case, the one that opened the whole thing. Hey, James, how about we start with a relatively common injury, which is scaphoid fractures. So somebody falls on their outstretched hand, and they come in with typical pain over the scaphoid, swelling and pain right in the snuff box, pain on axial load of the thumb. And you do an x-ray in the emerge, and the x-ray is normal. What's your advice to us?
I get this question all the time. So I would have to say that depending on where you are, your algorithm is going to be a little bit different. X-ray really isn't that accurate when you're looking at a scaphoid. The anatomy of the scaphoid, it's incredible. The scaphoid means boat. It doesn't look like a boat at all. But because of the orientation, you can't commonly see these oblique fractures on X-ray, especially if they're non-displaced. CT scan is a modality that we use all the time, and I love it. And with the newer CT scanners, you can actually get a really good picture, and it's rare to miss a scaphoid fracture with a CT scan. So I always say, if the x-ray shows nothing and your clinical examination still says scaphoid fracture, get a CT. They're easy to get in Canada, and it'll probably give you your answer pretty quickly.
How about if you're in Bella Bella, though? There's no CT scanner there.
Therein lies the problem. So this is why the algorithm, depending on where you are, is going to change. If you're in Bella Bella and you have no CT scanner, you're probably going to throw them in a splint and bring them back in 10, 14 days and treat them as if they are a scaphoid fracture in that interim, and then re-x-ray them.
So let's just say the same patient. I do a plain film of the scaphoid. It's negative for fracture. I do a CT. It's also negative for fracture. What would you advise us at that point to do?
What is your preclinical diagnosis? And if you're still thinking scaphoid fracture, at that point in time, send to the hand surgeon. They're going to do the exact same thing. They're going to reassess probably in a few weeks, and they'll get another CT scan. And whether there's a fracture or not, you're still probably going to send to the hand surgeon. So go for it.
Yeah, that sounds reasonable. Eric, what are your thoughts on that?
Does the CT ever give you information about a fracture that changes your management? Say if someone just had a plain film showing a fracture.
All the time.
So if someone comes in tomorrow when I'm going to my shift and they're tender over the scaphoid, why don't I just send them for a dry CT? Just because that, if it diagnoses their fracture, great, and it gives you more bony information.
This is when you're going to have to rely on the algorithm of your local hand surgeon. So me personally, the way that I was trained and the way that I now see my scaphoids is that for all scaphoids, I'll get a CT scan. If they've come to me with a plain film that shows it's obviously fractured, I still get a CT scan. And that can commonly show things you didn't see before. Comminution, significant displacement, which may be in the plane of the x-ray. So suddenly your treatment algorithm is different. I'm going to take that displaced scaphoid to the operating room and I'm going to fix it. But if it's completely non-displaced, I'm not going to take it to the operating room. It's be conservative management. But more important than that is scaphoids, the big problem with these is they don't want to heal. So you are now 8, 12 weeks out. They're still painful. What do you use to assess clinical healing? CT scan. So I'm going to be comparing the initial CT scan to the CT scan 8 or 12 weeks out. And that's really useful.
Okay, that totally makes sense. What's your recommendation for splinting? I mean, I've been putting just them all in thumb spicas, like a fiberglass thumb spica. Is that good enough, or do you have a better way of splinting them, or is that adequate?
That's perfect. I tend to use splints because they're easier to take off. It's a bit of a pain in the butt to remove a cast for every one of these guys, and they're not going to get that much different immobilization in a splint versus a cast.
And you're cool with fiberglass versus plaster?
Totally fine. It doesn't make any difference. It's all being cut off at the end, so it doesn't really matter what you're using.
So the next common fracture that there's controversy about would be a boxer's fracture. So boxer's fractures, let's just say it's angulated 70 degrees. There's no malrotation. It's a 30-year-old male who works as a carpenter and has been in an altercation, but the skin's intact, but there's a boxer fracture. So I think there's actually large variability amongst emerged docs as to actually what they're going to do with that boxer's fracture. Are they going to just splint it and send it to plastics, or are they going to try to reduce that thing, or what? So what are your words of wisdom on these boxer's fractures?
So I'm going to throw this back to you first. So what do you mean by a boxer's fracture? I have an idea in my mind what a boxer's fracture is, but so often I get boxer's fracture, and I'm putting my hands up in quotations here, when it's not actually a boxer. So it's the neck, it's not the head, it's not the distal shaft, and it's only the fifth metacarpal. So boxer's fractures. I get this question weekly. What do we do? And the answer is probably no matter what you do, they're going to be fine. And that's the honest answer. You could put them in a tensor bandage and buddy tape their fingers and tell them to go back to work, and they're probably going to be totally okay. And there's numerous studies showing that. It started off in the 80s in a study out of the UK, which basically was looking at, all these welders and iron workers, and they were fine. There was essentially no complications. I think it's a little bit different when you're looking at the 16-year-old kid who punched a wall, and he may want to do something with his hands at a later date. So he's probably going to be okay.
You mean like a plastic surgeon, perhaps?
Maybe the bratty little plastic surgeon. That guilty, yes. So there's a small chance that these individuals could end up with a significant deformity, which would lead to an extensor lag of the small finger, decreased grip strength of the palm, because that's where your grip strength comes from. It's from the ring and small finger. Or they're going to feel like there's a ball over their metacarpal head as they try to make a fist. And if they get one of those complications, suddenly they need operative management. Rotation can happen as well, but it's not as common with a small finger. So in those individuals, they need a larger surgery at the end of the day. So you're trying to do something to minimize those risks. So what can you do, which is really simple? Reduce it. It's next to nothing to do it. It takes 5 minutes. And then put them into an ulnar gutter splint. It is an extra step. It sucks doing it at 2 o'clock in the morning when most of these guys come in and they're intoxicated and not happy, usually with an angry girlfriend in tow. But I think that it really prevents those small complications which could happen.
So you're recommending for a patient that potentially like a concert pianist or somebody who might be doing very, very fine movements with their hands, and it's significantly displaced boxer's fractures, that we should try to reduce those in the emergency department.
I think for boxers, if you have more than 60 degrees of angulation, that's kind of the magic number here. We tend to say reduce it. Or if you think that it's going to be somebody who may be high demand on their hands at some point, there's no harm in reducing it. You're really not going to burn any bridges doing so.
What about the alternate plan, which would be just to refer it to plastics, put them in an ulnar gutter splint, and get them seen within the next 2 or 3 days and get them to maybe get it pinned or something like that, versus just trying to reduce it?
Well, look at the other end of this, the coin there, and that is, if you're pinning somebody's metacarpal, there's complications associated with that as well. So suddenly they're going to have a small surgery. They could have tendinous adhesions, which may need a secondary surgery to free up those tendons. So we really try to minimize surgical intervention. So even if you refer to a plastic surgeon, the first thing we're going to try to do is reduce it and try to, conservative management in a splint. And we're only going to operate on those that are unstable. And that's rare. Yeah, that's probably 1 out of 20 or 30 metacarpal fractures, or boxer's fractures, I should say.
Cool. Yeah. And once again, to splint it, you're happy with an ulnar gutter splint? Ulnar
gutter, position of safety. More often than not, I'm now leaving the IP joints free. Gives them a little bit of range of motion so that they can wiggle their fingers. The MCP joint is still bent down to 90 degrees, but the IP joints of the finger will still move.
Okay.
And that will minimize how much stiffness they have when they come out of their cast in 6 weeks.
Right. Okay. So you're doing probably an ulnar nerve block, right? That's what I do anyways, but
I don't. I do a hematoma block. I love the hematoma block.
Oh, you're doing a hematoma block. It's a game changer for me.
Really?
I'm not using hematoma blocks ever on a boxer's fracture. I've always been doing ulnar nerve blocks. So that's I'm going to do that next time.
So I use a 10 cc syringe, Lido 1%, with epi typically, and on the back you can see where they're most painful, over the back of the metacarpal. I'll drop the needle right onto periosteum, and I'll bounce along the periosteum until I feel the needle go into the fracture site.
Right.
Usually, if it's a fresh fracture, you can actually aspirate a little bit of blood. Then you know you're in the hematoma. And then you inject 2 cc's and they're numb.
It's just like a wrist fracture, really.
Exactly.
So I do hematoma blocks on a wrist fracture. I have no idea why I'm not using them on boxer fractures, but thank you. That's going to change my practice there.
First 3 or 4 days after the fracture, you can't go wrong.
Let's move on to a different fracture, perhaps. So mallet fractures. So for the audience, I'm actually showing him my mallet fracture, which is right here, and it's mostly healed, but quite functional.
So we're talking mallet fractures and not mallet injuries.
How about we do both?
Different beasts.
They are different beasts. Yeah. All right. Well, let's first go with mallet fractures. Which mallet fractures need to be pinned?
Okay. So when I look at mallet fractures, there's usually the most common fracture pattern is you have the bigger fragment, which is associated with the distal phalanx, and then you have a smaller, almost like an avulsion fragment, which has come off the dorsal base of the distal phalanx. And that's commonly what you see. So if that larger distal phalanx is in alignment with the middle phalanx, it's not subluxed volarly, that's probably quite stable. And if that smaller avulsion fragment is in close proximity and it just looks like it's going to heal there, leave it.
All right.
They don't need surgery. But that little avulsion fragment, that's going to give you a lot of information. So that tells you where the distal extent of that tendon is now, that extensor tendon. So if that's pulled back a long way, you probably need to get that back into a better position. And that may need a little bit of a wire to hold it there while it heals. Mm-hmm. So even though that main fracture fragment's in a good position, that little tiny avulsion fragment's just giving you that information. But the other scenario is when you have that larger fragment, the distal phalanx is volarly subluxed. And that's going to tell you that you probably have ligamentous instability as well. And those guys probably need to be pinned because it's the flexor tendon is wanting to pull it out of position.
Yeah, that's the way my finger was, actually.
Yeah. Did you have it pinned?
I did.
Are we allowed to talk about personal medical history here?
Yeah. So one of the plastic or hand surgeons actually did that, and that just saved my finger. That was great. So say there's a mallet finger, but there's no fracture. Mm-hmm. I mean, obviously we're going to splint those, but there's a lot of controversy about how to splint them. I mean, I think everybody knows that we have to splint, refer to a hand surgeon. But how do you splint them? What's your best recommendation of how we do that in Emerge?
I'm always surprised at how many don't make it to us. I get a huge number of delayed presentation mallet injuries that have either been identified and just told that it's going to be fine, or they're being treated in the community.
Well, that's very interesting. How about you, Eric? Have you come across that?
I'll have to be honest. I've not sent all pure mallet fingers, or jersey fingers, as we used to call them in the rugby days, right?
Your jersey's different, though.
Yeah.
That's a flexor tendon injury.
Really?
Yeah.
So jersey finger is typically the mechanism for that is it's called a jersey finger because you're grabbing the jersey, which gets wrenched out of your hand. And as your flexor tendon is trying to pull, it actually gets pulled right off the base of the distal phalanx. So that's flexor tendon.
Oh, I stand corrected. Yeah. Okay, if we go back to mallet finger, then I've just been splinting him in hyperextension and saying, keep it on for 6 weeks, and that's it.
So if they do that, they're probably going to be fine, but nobody does. They always take it off just to test it. So we have a Mallet Protocol, which is probably the easiest protocol known to man.
The Mallet Protocol, that was a book by Robert Ludlum. I'm pretty sure it was. The Mallet Protocol.
That was the protocol I used for my kids. So I want to hear your mallet protocol because I actually have a bias in this because I have a mallet finger and I personally think they should all be referred to a hand specialist. That's just my own bias.
This is like scaphoids and it's like metacarpal fractures. Is that most likely they're going to be totally fine? But it's that small, 3 or 4% of them that when they go wrong, they go really wrong. So my mallet protocol, treat them as soon as you can. And you put them into a splint, which puts them into just a little bit of hyperextension of the DIP joint. And they need to maintain, not the splint, but that position for 6 weeks.
Do you put the splint on a dorsal aspect of the finger or the volar aspect?
I prefer the dorsal aspect, just because it means that they're going to be a bit more functional. They can still hold a pencil if it's their index finger. They can still play the piano, whatever they want to do. And I encourage them to use their hand lightly.
Now, we have these funny little plastic splints that have a hole cut out at the tip. They're called mallet splints. Are those any good at all?
Those are fine, but people tend to get a lot of irritation with those. They don't breathe very well. They get very macerated, and they tend not to be as compliant. So believe it or not, I actually refer all my mallets to get a custom-made orthoplastic splint from my hand therapist. And this is my second plug for the hand therapist. I can't say enough good stuff about them. They will make comfortable splints. They'll make patients much more compliant. They'll reinforce what we've already said. And they save my bacon day in, day out.
So I echo this because I've hurt my hand so many times, and I've seen a hand therapist like multiple times, and they're like they've saved my hands. So I totally echo it.
Exactly. So they make a custom-made orthoplastic splint, which is perforated. It is circumferential, but it basically locks the DIP joint in a little bit of hyperextension. And because it's comfortable, they can wear it for anything. They can go back to sports. They can do essentially whatever they want, as long as it's not going to put them at risk. So if they're climbing ladders for work, I say probably not the best of ideas. But other than that, do whatever you want for the 6 weeks. Just whenever you clean that splint or take it off, your finger has to either be supported on a table so it can't bend, or with your thumb so that it's always held in hyperextension. Then you clean the finger, you put the splint back on, and not once in 6 weeks it is ever let to bend. If it bends once, you start the 6 weeks all over again.
So just to be clear, the splint is actually from the PIP joint to the tip. It's not the entire finger, correct?
It's not the entire finger. It immobilizes just the DIP joint. So it covers the middle phalanx and distal phalanx.
Right, because I've seen a lot of people put long splints.
No point.
And there's no point in that.
No point. No. The only time you do that is if you get these weird and wonderful, when suddenly the finger is starting to assume an immediate swan neck deformity. And then, you can put whatever splint on you want, because they're going to be...
No, I don't have a swan neck. It's almost a swan neck.
Those ones, it's even more important that you refer them to a hand surgeon, because they need to be monitored very closely to prevent that from becoming a functioning deformity.
All right. How about, Eric, one more fracture? Would that be good? And then we can move on to dislocations. I'm thinking maybe tuft fractures. We see tuft fractures all the time. They hit their finger with a hammer or some other blunt object, and they have a shattered tip of the finger.
That's the classic WCB tuft fracture.
Classic tuft fracture.
And let's talk about open versus closed.
Oh, that's a good call.
Yeah.
Because why, Eric? What's the difference between open and closed?
Well, I'm interested to hear what James would have to say, because I have dismissed closed tuft fractures and said, have a nice day and just get on with things, and your fingertip's going to hurt, and that might happen. Open fractures, I'm not sure if I should be more worried, but I've seen different things from different plastic surgeons about what I should do about those. So yes, I'd like to know what you do about those.
And let me just jump in there, because a lot of these closed tuft fractures have a subungual hematoma, and you trephinate it, and then you make it into an open fracture. So eventually, a lot of them are going to be open fractures. So yeah, what do you have to say there?
Okay, I see this all the time as well. When you have a tuft, or let's actually go back to anatomy. My job is about anatomy. And if you understand anatomy, then you can actually predict what's going to happen. So the distal phalanx and the tuft of the distal phalanx, what is its job? Its job is to support the soft tissues, and it's essentially intimate with the overlying nail bed. So if you have a significant tuft fracture, that nail bed's going to tear, and you're going to get a subungual hemorrhage. Okay? So that tear in the nail bed is an indication that there's something happening underneath. So maybe we should divide this into tuft fractures that, as you said, that are open versus closed.
Sure.
Okay. Tuft fractures that are genuinely closed, i.e. no hematoma, there's no open. I think they're going to be totally fine doing symptomatic management. Put them in a splint. When it stops being painful, take the splint off. They probably don't need to see us.
It's just a protective splint.
It's just a protective splint. And these guys, typically they want to get back to work. And they're going to be fine. And usually I find that they wear that splint for 2 or 3 weeks. And even if I tell them they need to keep it on, they don't. So closed tuft fractures, yeah, I agree. Treat them very conservatively. The open tuft fractures can be a bit more challenging. If you have a subungual hemorrhage, you have a tear in the sterile matrix of the nail. And if you have a tear, you're going to get scar tissue. If it's not fixed and that scar tissue becomes significant, they're going to get dystrophic nail growth. And that's the big one there, is we're trying to prevent that nail from growing abnormally. So when you see a significant displacement or hemorrhage, it's not a bad idea to actually get that nail plate off, fix the nail bed injury to minimize the risk of them having a dystrophic nail. So I tend to do that with all of my open tuft fractures.
This is a great controversy because
I can tell you
there are
right.
some people who say you got a significant nail bed injury, just to leave it alone. So that's the controversy. But you're saying that it's actually better to take the nail off and do a formalized repair because you've noticed.
Commonly, I do a formalized repair, and then I won't splint. We can get into this another topic of do you splint or do you not splint afterwards. I tend not to splint them unless the nail bed injury actually advances all the way into the nail fold. If it's not within the nail fold, totally fine, no splint.
What about antibiotics? It's an open fracture, but do they really need antibiotics?
I don't give them antibiotics. There's been a number of studies looking at that, and there's not a really high indication that antibiotics are needed. I think you have to use your clinical judgment. If this is a nasty crush injury and it was, pretty gross, sure, put them on antibiotics. But for the run of the mill, I hit it with a hammer, it was crushed in a car door, they're probably fine without it.
So Joe, what percentage of your colleagues, well, here's a two-part question. What percentage will actually repair a nail bed? And what percent of them will actually go, oh, you got to be kidding me. I don't want to fix a nail bed, because they are time consuming. We don't do them a lot. And actually the thing is more that they're probably time consuming. You have to block the finger. You have to tease away the nail bed. It's not something we do all the time.
Yeah, I'm going to say it's 50-50 in our group. I bet you there's half the people who are doing formalized nail bed repairs and half the people are just splinting and referring to plastics or hands.
I bet you if you divide that up into people who are new into practice versus people who are more senior in their practice, you'll find that the newer individuals repair them and the more senior members don't. That's just a hunch. But I find that with plastic surgeons as well.
So there is also the problem with pain. Like a lot of these tuft fractures have persistent ongoing pain. Do you ever do desensitization therapy for those?
Every single patient. It's so important. So if you aren't going to be referring that conservative management tuft fracture to a hand surgeon, you have to talk about desensitization. And that is, they've crushed their nerves. Their nerves need to regrow and they need to recover. So you're going to encourage them as they do that. You're going to touch it on different textured surfaces. Your jeans, on a fleece, you're going to start eventually building up to the point where you can tap it on a surface lightly and then gently. It's a simple conversation that takes 3 minutes, but I find that it takes that 3-minute conversation to happen 3 or 4 times before they actually do it. Yeah.
That's awesome, James. Okay, Eric, over to you.
Sure, let's move on to dislocations. So let's talk about that typical dorsal PIP dislocation that we see pretty commonly. And just before we started recording, we started talking about one of our colleagues actually dislocated multiple PIP joints and actually self-reduced in the field. Joe?
Yeah, that was me.
Are we going to tell the story?
I can briefly tell the story. So I was kayaking on Clayoquot Sound and we were camping on Three Fingers Beach on Vargas Island. And I was foolishly climbing a sea stack and asked my wife to take a picture of me in one of my narcissistic moments. And I climbed up the sea stack and the rocks broke away and I fell down and dislocated 3 of my fingers on my right hand, which I promptly reduced immediately. But boy, that hurt a lot.
I think you were smart to reduce them, personally.
I think there's also the spousal anger factor, which probably was quite high at the time.
Is there a formalized scale for spousal anger factor?
If it is, I'm not told about it. I just hit a 10 most of the time.
The SAF scale?
Yeah. Well, I'm glad you self-reduced. So my main questions about these fractures is, what are the reasons for splinting these after you relocate them? Do you just buddy tape them or do something different? And also, how worried really are you about the volar plate injury? And is this something we really need to stress about, or are most of them going to be fine? We have the luxury of referring to you because you're close, but smaller communities won't. What should people do about these really common injuries?
So this is going to go back to that, this knowledge of anatomy. We're always playing this game between stabilizing an injury versus encouraging range of motion to making sure it doesn't get stiff. So stiffness versus stabilization. If you splint something, you're going to encourage it to be stable, but you're going to prevent it from developing that range of motion. With these PIP joint injuries, if you put them through a range after you put them back in and they're stable in the entire range, why are you immobilizing them? They're already stable. You just don't want them doing anything too adventurous. So in those individuals, 100%, just buddy tape them, get them moving again. And I usually say buddy tape for a month full time, and then after that, start moving normally. So what is this, the volar plate? Volar plate is that little ligamentous structure on the bottom of the PI. Well, it's on the bottom of majority of the joints in the hands. But when you get a dorsal dislocation, you're tearing that structure. And so it's going to start to heal with scar tissue. And as all scar tissue does, it shrinks. And if it shrinks too much, you're going to start to develop a flexion contracture. So that's pretty rare. I'd say that probably only happens 1 out of 20 times. And if they're aware of that and they know to look out for it, they're probably fine. Yeah, I would, for all of these guys, if they're stable after the reduction, just buddy tape.
Yeah, and so I think to emphasize that, don't splint these if they're stable after reduction. Just buddy tape.
Exactly. So the dorsal dislocation, if it's a strict dorsal dislocation, the collaterals are usually intact. And the collateral ligament injury is very different than a volar plate injury, right? So if it's dorsal dislocation, only the volar plate is injured and you can buddy tape. If you have a collateral ligament injury, what's the treatment for that? Buddy taping. You just decide which finger to tape it to. If you have a collateral ligament on the long finger, and I know everybody listening to this is going to be looking at their hand doing this. If you have a collateral ligament on the radial aspect of your long finger PIP joint, it's going to want to open in an ulnar direction. So to prevent it from doing that, you're going to buddy tape it to the index finger.
Yeah, that makes sense.
So you may just, if you feel like there's a little bit of stability side to side, just choose which finger to buddy tape it to. The instability that you're worried about with these dorsal dislocations is it going to suddenly sublux or dislocate dorsally again when they make a fist? Right? Can they go from a neutral position to a fully flexed position? Are they stable in the PA direction?
Got it. Joe, you had a question about metacarpal dislocations.
Yeah, so I had a case not long ago of an irreducible metacarpal dislocation. So it was a complex dislocation. And my understanding is that the metacarpal head buttonholed through the flexor carpi superficialis tendon, and the soft tissues were in the way from the tendon. It couldn't be reduced, so it had to go to the OR to get fixed. Is that the correct understanding there?
So this was a CMC dislocation where the metacarpal base was volar?
That's right.
So that is much less common. Usually when we see CMC dislocations, they're popped out dorsally. And that's because of the mechanism of injury. What they typically do is it's a high energy fall. Their hands are outstretched and the metacarpal base pops up dorsally. There's a lot of stuff. That's the anatomical term, stuff, in the palmar aspect of the hand. And it can buttonhole through or even just pierce through the ligamentous structures. The other thing that can happen is you can develop a lot of either hematoma, bone fragment, or even that balled up ligament can be within the fossa of the carpal bones. And if that's the case, you can't get it out. And every time you try to get that metacarpal to sit in that fossa, it just wants to pop out again.
Right. And I think the same thing can happen too at your metacarpal phalangeal joint as well, right? You can get a complex one there with the dorsal dislocation.
It can be dorsal or volar. You can get these.
I've actually had one of those as well that was irreducible.
And those are horrible. Those are really frustrating because you think it's going to be simple and it's not.
So I guess the bottom line is if you can't reduce it, just don't keep going at it because some of these are not reducible.
I would say that the best thing you can do to try to reduce them, which isn't going to do that much damage, is slow, longitudinal retraction. So if you can get them nice and blocked so that their entire arm and the shoulder and the elbow are relaxed, and you pull on that finger pretty firmly for 2 minutes, then try it again, that's commonly successful.
Finger traps?
Finger traps are awesome as long as you're not going to get any pressure injuries. Old school. Yeah, they're useful for the, I like them.
Now, this is a bit morbid, but whenever I see somebody who falls on their wrist, I wonder what they might have, but I find myself secretly hoping that we'll have one of those cool perilunate fractures that look so awesome on x-ray.
I was waiting for that, yes.
And they just don't happen that often. But when we do see them, they're usually pretty easy to see and sort out. But I'm just curious about reduction techniques in the ED. How successful do you find people are doing them? And do you have any special tricks for reducing those that we might not do?
So I think the same principles, the mechanism for that perilunate dislocation is going to be the same for that CMC dislocation. It's going to be a high energy injury. Typically, you're landing on an outstretched hand, so you're landing on your palm. So we see this in the mountain bikers. They go off some sort of, large gap. They land on their hands. Skiers, if it's on icy surfaces, borders as well. But for those longitudinal traction, getting them nice and relaxed, if they're tense, it's never happening. There's so many structures which are pulling across that joint. So all of the flexors in the forearm, all the extensors in the forearm, if they tense up, they're pulling that joint tight and you're never going to move it. So you need to get them super relaxed. Conscious sedation is pretty much a must. Okay. And then what you want to do is recreate the injury. So hyperextend that wrist, longitudinal traction, volarly flex the wrist, and try to get that lunate back into position, because almost always these lunates are volar, right? They've been dislocated dorsally and then pushed volarly. Yeah.
And I've seen these before too, where they actually have like an acute neuropathy, like they just have burning pain and numbness in their hand. And
red flag.
I kind of feel that sort of thing really should be reduced and emerge if you possibly can.
There's really not that many plastic surgery emergencies, which is why my job is great. But that's one of them. So we have neck fash, we have an amputated finger, which will get our blood pressure going a little bit. But these compartment syndromes, or more so, this is pressure within the carpal tunnel, because that lunate, as it's being dislocated volarly, it's being pushed into that carpal tunnel, which is that space can't expand. So all the contents, tendons don't care, but that nerve, it's being pushed, and you have an acute carpal tunnel. That's a surgical emergency. So if it can't be reduced, they need surgery.
When do you see that present? Is it right around the time of injury, or can you get those post-reduction?
You can get them post-reduction. You need to follow that closely. Typically, you'll get it in the post-reduction, which is unstable. So will have, and that's an indication that they've redislocated. Mm-hmm. But usually these individuals will come in an extremis kind of presentation. They will be numb hand, huge pain. Almost always they come directly from the injury. They're still in their mountain bike gear.
I've seen this a couple times. It's like they're yelling. They're in terrible pain.
Yeah, it's that classic personality change. Once I had a guy go home and print off the medical marijuana license. He did that first before coming, because he wanted me to sign that to make sure that this was before it was legal. So that was his primary concern. You can guess how he injured it.
That's a man planning.
I thought it was very thoughtful.
Exactly.
Yeah, foresight.
Didn't want to waste your time, wanted to get things done for himself, advocating for himself.
What do you think, Eric? Should we go to amputations next?
Let's chop off some fingers.
All right, let's chop off the fingers. Okay, so some guy comes in and he's chopped off some fingers in a industrial accident. And they brought the finger in. It's on ice. What's your advice to the emerged physicians? What fingers can be reimplanted? What cannot be reimplanted?
It wasn't until fairly recently that we're actually able to do this. So if you start looking into when we could actually put a finger back on, it was only in the 70s that we actually were able to start doing this on a consistent basis. And I think, like a lot of other medical procedures, as soon as you know that you can do it, you do it for everything, because it's pretty cool. Like, let's just face it. It's a cool thing to do. Fingers cut off, put it back on. That's awesome. So for a long time, we were putting everything back on. And there's still a couple of places that still do that, mostly in the States. It doesn't matter where the tip injury is. It doesn't matter how much the finger, they'll put it back on. But the majority of the hand surgery world is actually going away from that now. So we have much more, not so much guidelines, but much more relaxed trends in what we'll put back on. So single fingers. If you have a single finger amputated, it probably should not go back on. The thumb is a different story. So if it's a single finger, it tends not to go back on, or a pediatric case. If you're a pediatric, they actually do quite well. But the reason we don't put single fingers back on is because they get stiff. They actually get in the way. If my finger was cut off, I don't want it back on. It doesn't matter if it's the entire thing, it's staying off.
Okay, hold on. James does not want finger reimplantation. Got it.
So even the index finger, because the index finger and the thumb kind of form a pincer mechanism, and
the index finger
to pick up peas, and
it's the most useless finger you have. If you are ever taken hostage and they want to send proof of life, ask them to take your index finger.
Hang on a sec. Hostage advice from James: cut off index finger first. This podcast is yielding such awesome pros.
This has so many life applications, doesn't it? So I'm going to get sued, aren't I?
So the index finger is actually probably the weakest finger and the most useless finger, and the best finger. Which is the best finger then?
Your most useful finger may be either it's of course your thumb, no questions asked. But besides the thumb, you're probably looking at either your long finger or your small finger.
Not the ring finger.
The ring finger is kind of a bridge between the two.
Certainly, I know the power in your hand is those last three fingers, the little finger, the ring finger, and the middle finger. They're mostly, the powerful.
Because of the line of pull, mostly the small ring fingers where all your grip strength comes from. Your index finger and your long finger are used for dexterity. And if your index finger goes missing, you can do everything you used to do with your index finger with your long finger.
Oh, that is cool. That knowledge that I did not know.
So lose your index finger if you have the choice, but I don't know anybody who's had the choice which finger to lose. So when do we put them back on? We've talked about the single finger.
Yeah.
If we have multiple digits, we tend to put them back on. If it's a thumb, we'll put them back on. And if it's a pediatric scenario, we'll put them back on.
How about as far as how distal the amputation is?
So the further distal it is, the harder it is to put it back on and the less functional importance it has. So if you have an amputation at the base of the finger, you're going to lose all function of that finger. But if you have an amputation, let's say through the distal phalanx, you're still going to maintain most of your function. And, we probably wouldn't put that back on. The anatomy plays a big role in what we do there. So the caliber of your artery gets smaller and smaller as it goes more distal in the finger. And then roughly at the flexion crease of the DIP joint, it trifurcates. And at that point, it goes from being about 1 millimeter in size to being tiny. And it's really, really hard at that point.
So I think pretty much anything after the DIP joint's almost impossible to reimplant.
There are some places that do it. We tend to call it super microsurgery, but I can probably count on one hand how many times I've seen that in the last 15 years.
Yeah, and of course, I guess it also depends upon the quality of the amputation. We're talking surgical amputations here, not mangled, destroyed tissues and stuff like that.
Mechanism is so important, yes. If it's a guillotine type action, that's going to be much easier to repair than if it's being avulsed and you have
crushed severely.
Oh, horrendous.
Yes.
Just horrendous.
So if there's a massive soft tissue injury, crush injury, that would factor into it, wouldn't it?
Yeah, you think about the hand. If they have a crush injury, they're going to have more than just a finger amputation. They're going to have soft tissue, scar tissue formation, which is really going to limit the functionality of their hand. If you put that finger back on, it's just going to get in the way. It's going to be a painful, non-functional fingertip, which will prevent them from doing normal rehab for the rest of the crush injury.
So if you put the finger on ice, probably in a bag of water in ice, I guess that's the best way, isn't it?
Yeah. So never put the finger directly in contact with the ice. Typically, you want to put it onto some moist gauze in a little baggie, and then that little baggie into the ice.
Right. Okay.
Yeah, otherwise, getting a frozen finger
and
just sucks.
if you do that properly, like you don't put the finger right on the ice, you go, 6 hours?
Yeah, longer than that. Probably up to 12.
Up to 12 hours.
A little bit longer.
So if you're in Queen Charlotte City, it's important for the smaller towns, the smaller communities that don't have a plastic surgeon, that this is something they can still get out, maybe.
The sooner you get them to the center where this is going to happen, the better. Like, let's just straight up, the sooner the better. It's not like there's, at 12 hours they're okay and at 12:01 they're not. This is a slow process. If they're on ice, you probably have 8 to 12 hours. And I would say, don't count against it if it's an 8-hour-old injury. Still try to get it to them, and they can have that formal assessment. If it hasn't been on ice, it's significantly shorter. You're probably looking at 4 hours or so. 4 to 6 before it turns into a big mess. Yeah. I have a patient that I love to meet some of my other patients. So he's a firefighter, and he actually lost the fingertips of all of his fingers to the level of about the PIP joint. And he had them amputated. There's no way he could put it back on. It was frostbite. And he now functions incredibly well. He's still a firefighter. He still does everything. He's got a prosthesis, which he sometimes uses just because it's pretty cool. But the majority of the time when he's working, doing his day-to-day stuff, he doesn't use it. So he's just got on to life. It's awesome.
So I guess another related topic to amputations would be the digital nerve injuries.
Yes.
So tell us about what your thoughts are on that, because I think most digital nerve injuries probably don't need to be repaired, but some do, correct?
I would disagree with that.
Okay.
Yeah. And I am coming from I'm a peripheral nerve surgeon. So a big portion of my training was spent doing nerve surgery, nerve injuries. So peripheral nerves, they want to grow. If you cut a digital nerve, it's going to try to grow. But the question is it going to grow into the right spot? So think of it kind of like a tree root. You need to encourage it into the right spot. Otherwise, it's just going to go haywire. So yeah, most of the time, if you don't repair digital nerve injury, they're probably not going to regain sensation. And for some areas, that's not really important. But there's a moderate chance they can develop a painful neuroma. So that nerve's trying to grow. It's going to grow into a ball. Anytime you tap that, you're going to get these electrical shock-like sensations. That's hard to fix. Down the road, 2-3 years, you're not going to fix that. So that's why we tend to repair the majority of them. So if it is same thing with that artery, the caliber gets smaller and smaller as you go more and more distal. So if you are proximal to the DIP joint, we're going to repair it. If it is distal to the DIP joint, it's trifurcated, it's too small to repair, and they tend to do fine on their own at that level. So 2 reasons. 1, try to get as much sensation back as possible. And usually I tell the patients, but 80 or 90% is a really good recovery at 3 years. So if we repair it, you could get 80, 90% at 3 years, but it's going to take a while. I know that if my digital nerve was cut, I'd want it repaired. No questions asked. Yeah. Even if I didn't get any sensation back, I'd still want to just minimize the risk of a painful neuroma.
Yeah.
What's the time frame on that, though? If I see somebody on Friday night and they've lacerated their hand and I realize, hey, you don't have sensation distal to that. Can they wait 3 days?
Oh, yeah. Yeah, we'll commonly repair them 7-10 days afterwards. The quicker the repair, the better the recovery.
As you said, there are very few hand emergencies.
Very few. Hand compartment syndrome, maybe? Amputation?
I'm glad you brought up hand compartment syndrome because I'm not sure I've ever seen it, in which case it's rare, or I've missed it, or both.
Well, what about with infection, though? Like, what about septic tenosynovitis? Does that not cause a compartment syndrome within the flexor tendon sheath, and it's sort of an emergency?
It is essentially compartment syndrome. So the hand is divided into a whole bunch of different compartments, and that's why your tendons stay where they're meant to be. So if you get pressure built up in that one compartment, you're going to get pain and you're going to get all the symptoms of compartment syndrome. Same thing with a button abscess. If you get an abscess within the web space, it's a confined space, and they're going to get a kind of pseudo compartment syndrome. So yeah, I would actually say that a flexor tenosynovitis is a very good analogy for compartment syndrome in the hand. Yeah, I think whenever I hear compartment syndrome in the hand, I commonly have people saying, "Oh, the whole hand is very swollen. Does the entire hand have compartment syndrome?" And other than burns, I'm not too sure if I've ever seen that happen.
The Felon, that's a compartment syndrome as well, and that's incredibly painful.
Yeah, that's another confined. All the little soft tissue attachments that attach the skin to the distal phalanx and prevent it from moving around, because that's why it works the way it works, basically constrict that area. So if you get an expanding mass in that area, it doesn't want to expand and it hurts a lot.
What's the best way to drain a Felon?
Whenever you drain a Felon, you have to think about the resulting scar. So every finger has a dominant side and a non-dominant side. And the dominant side for your index and long finger is the side that opposes to your thumb. That's the important side. And the dominant side for your ring and small finger is the side that traces along the table as you write.
Right.
And so you don't want to put a new scar on the dominant side of the finger. So put it not on the pulp, but on the side and on the non-dominant side.
So that's another practice change for me.
Yeah, perfect.
I've been doing central incisions, so I think that I'm going to do what you're saying now.
So what have you been doing right in your practice so far?
Yeah. Well, I've lasted this long. I guess should we go back to our first case, our very first case?
I think pretty soon. I just wanted to expand a little bit just for James's sake on flexor tenosynovitis and Cannibal Signs, because he told me about those signs, something I did not know. Joe, do you remember the Cannibal Signs?
So I'll try to remember what they are. So that's...
Time to redeem yourself.
Yeah, so there's pain along the flexor tendon. There's swelling of the finger especially on the volar aspect. The patient's finger is in a flexed position, and there's intense pain on extension of the finger. In fact, you cannot extend that finger. So those are the Cannibal Signs that I know.
So those are the 4 Cannibal Signs.
Yes, but is there a fifth?
There is indeed a fifth.
There's not this is a fifth that I would like to make an addendum.
Okay.
All the time. So we get, I can't tell you how many times I get referrals for either neck fash or flexor tenosynovitis when it's very obviously not. And the physician knows that it's not, but they're basically it's crossed their minds, so they need to rule it out. So in my mind, for both of those, the fifth one is change in personality. If this patient is, flexor tenosynovitis hurts a lot. And it hasn't typically been there for 3 or 4 weeks. It hurts over the last 24, 48 hours. It's getting worse. They're angry, miserable people that you don't want to see, right? So they're going to be holding their hand. They're not going to want to move it. And they just have that angry patient sign. So if they have that, it's a much higher indication for me that there's an active flexor tenosynovitis going on.
And I would like to put out there that it's one of those diagnoses that is not uncommonly missed.
Like it's missed all the time.
So
it's incredible.
Like we have this outpatient IV therapy area, and occasionally you pick it up like the next day, and it may not have been even obvious the very first day, but you pick it up the next day, and they've clearly got a flexor tenosynovitis, and they need to see you or a hand surgeon like you.
So I would say the other golden fact there is we always palpate over the area of tenderness, but it's flexor tenosynovitis is inflammation of that entire flexor tendon sheath. And that sheath goes a long way down into the palm. So if they have an area of erythema and fusiform swelling of the digit, you should be able to palpate over that same sheath at the level of the palm, and they should still be painful there. Or alternatively, if they're most painful in the palm, you should go all the way to the tip of the finger where the sheath still is there and still get pain on palpation over that sheath.
And I've actually seen some patients that it was delayed, the diagnosis was delayed long enough that the flexor tendon was actually was ruined, like really badly ruined, and they couldn't use the finger afterwards, and it was like a dead finger. So it's a diagnosis you've got to pick up.
That's a bundle of hurt when that happens. Those tendons you can't repair. You end up debriding them, and then you end up doing a staged reconstruction, and the finger's never normal after that. Yeah, sometimes you're right. Amputation sometimes is the best way to go.
Before we get back to our case, this is putting James on the spot, but I wondered if you could think about 1 to 3 things that you see that we either miss in the ED or don't manage perfectly, things that are recurrent that we may not even know about.
That's hard. This is not a me sucking up, but I actually do have the privilege of working in a hospital where the staff that I work with are hugely experienced in sending me referrals. So I think that for the most part, more than I've ever worked before, I don't see a lot of missed injuries from my ED staff, which I love. I think that a lot of the things that are referred to me are probably things that I miss as well. And the most common is the second fracture. So they've been sent to me for, multi-trauma injury. They've got the carpal dislocation, but what we haven't seen is the PIP dislocation, that by the time it's picked up at 4 weeks, they're in big trouble. So I see that fairly often. I think the other one is the forearm laceration. You see a forearm and they say, yep, you got a nasty cut there. We're just going to sew you up. The exam is normal. If you look at the numbers, your number of injured structures before surgery is usually doubled when you actually go in and have a look. So the penetrating forearm traumas, it's usually much more complex than you think. You can have, quite a few lacerations to your tendons, and because of the interconnectivity of those tendons, they're still functioning fairly well, but that can be a problem down the road. So forearm penetrating traumas is a big one. And the last one would likely be condylar head fractures. So we see injuries to the base of the middle proximal phalanx all the time. But when you see intra-articular condylar head fractures, sometimes they're really not that apparent to start off with, but they slowly move, and those can be terrible to treat too. So usually I'll see most of those on a delayed basis when they're a nightmare.
So if we pick it up, we shouldn't be blasé about it and say, let's buddy splint these and have a nice day. We should make sure you review those within 10 days?
I would say definitely. Even though we may just buddy tape them, I still think they need to be reviewed or even just laid eyes upon.
So back to our case, the man had obviously punched somebody in the mouth and has a laceration right over the MCP joint. Eric, what were you thinking about this? You asked me about the case, but I'm putting it back to you now.
Sure. Well, I'm thinking my initial management, I give him some pain control, look at his tetanus status, see what was his dominant hand. If he'd had a prior injury, do a meticulous exam just to make sure his extensor tens nerve function and nerve function was okay. And look at the x-ray and then decide what to do about any fractures there, but also just think about this being a closed fist injury and what I need to worry about for downstream infection. So that's where I might consider empiric antibiotics instead of waiting, and definitely consider splinting these folks just so they don't move their hand around. And yeah, those are the things I worry about the most. Or of course, the people who may not own up to the fact that they hit somebody in the mouth. So
I see that all the time. Yeah. I think that hand injuries are so commonly embarrassing. They punched a wall, they were drunk, they were doing something they shouldn't have done. Or even they were doing something they normally do, but they're just embarrassed because they got injured and they don't tell you the whole story. So most of these guys come in the next morning, they have the classic fight bite presentation and they're adamant that they punched a wall, or they're adamant that it was at work and it's a small laceration. I always ask, if there's any chance that you could have accidentally cut this on somebody else's tooth, then we need to treat you for a potential infection with a separate antibiotic, which could potentially save your finger, because you may lose your joint or finger if we don't. And suddenly they'll say, there's a small chance it could have happened. And then you just treat them that way.
Anything else to further to that management for those folks?
Catch it early, then it's usually not a problem, but that septic joint is horrible, those fight bite injuries. Yeah.
And if they come in delayed, those are the ones you probably want to put on at least outpatient IV antibiotics, I think, and get a really early referral. Because I think oral antibiotics immediately for the ones that are that come in that are not infected, but the ones that already are infected, there you're starting to worry about septic arthritis. You're worried about bone infection, all kinds of other nastiness.
So that brings another question which I get asked is whether or not these are surgical interventions. Like, at what point in time do you irrigate a septic joint? And the answer is, more often than not, if it's an active infection, it needs to be irrigated. It's going to take too long to get that infection under control before it does significant cartilaginous damage.
Yet another emergency for you.
Yeah. That's one of the few.
Well, James, that was very, very awesome, and thank you very much.
Thanks for having me.
Time to wrap it up and call it a day. Thanks for tuning in. Feel free to post your comments and feedback on the BC Emergency Medicine Network website, bcemn.ca, and take a moment to check out the Clinical Resources tab with its clinical summaries and procedural videos, and visit the lounge to join in on member discussions, open up blogs, and access the End of Shift podcast library. Until then, keep your differential wide and go play outside.